नमस्ते आदरणीय व्यक्तित्वहरू आज म चाहिँ NENAP अर्थात् नेपाल एभ्री न्यूबर्न एक्सन प्लान को चाहिँ पार्ट सेकेन्ड चाहिँ पठन गर्न गइरहेको छु। हिजो हामीले चाहिँ स्ट्राटेजिक अब्जेक्टिभ फर्स्टसम्म चाहिँ पठन गरेका छौं र आज चाहिँ म पार्ट सेकेन्डमा स्ट्राटेजिक अब्जेक्टिभ टु इम्प्रुभ क्वालिटी अफ केयर एट द पोइन्ट अफ डेलिभरी बाट सुरु गर्न गइरहेको छु। The expansion of newborn care services need to be well supported by mechanism focused on the maintenance of quality in service delivery, is highlighted by the recent study of birthing center across Nepal that indicated poor implementation of national standard and guidelines. There is a strong need to renew the focus on quality of care at all levels of health facility, including those of public and private service provider. The bottleneck analysis emphasized that there is an ambiguity concerning some of the critical newborn intervention due to a lack of guideline and training to support their effective implementation. This is especially noted for kangaroo mother care, the management of congenital anomalies, preterm deliveries, severe newborn infection, and inpatient care for sick and small newborn. Updating existing newborn care guideline will facilitate health care worker and health facility to implement intervention according to acceptable standard. Additional attention will also be given to infection prevention measure practiced by the health facilities, particularly in terms of better biohazard waste management and improved water sanitation and hygiene facility for health worker and user. Cleaner health facility will pave the way for cleaner and improved quality in delivery and newborn care services. Quality assurance system will be strengthened through regular monitoring of quality and the implementation of quality improvement initiative to address area of concern. Adherence to standard by service provider will be promoted by communities mobilized to monitor provision of quality and by a strengthened regulation authority. Key output and action: deliver quality health services as per protocol and guideline, develop and enforce national guideline standard and clinical protocol regarding newborn care, including the management of congenital anomalies, preterm deliveries, KMC, service newborn infection, and inpatient care for sick and small newborn. Develop national guideline and training on the proper use of corticosteroid and tocolytics during the management of preterm labor for physician, including obstetrician, gynecologists, and MDGP to implement. Develop and conduct newborn healthcare training package for different health cards working at different health facilities, which will include up-to-date, high-impact, evidence-based intervention. Expand the use of chlorhexidine on the core of every newborn at all level of health facility and provide chlorhexidine to women presenting for ANC visit in 8th and 9th month of gestation to utilize in case of home delivery. Encourage health worker to refer cases in a timely manner using the aid to of partograph. Develop quality improvement strategies such as continue in-service training and audit to improve adherence to standard, and expand current licensing authority to become a regulation system that will closely monitor quality of public and private service provider to enforce adherence to acceptable standard. Quality of care at the point of service delivery from pregnancy through to the newborn period that include monitoring of preterm prevention in ANC, use of corticosteroid for the management of preterm deliveries, infection prevention in maternal and newborn health care, skill birth attendant at delivery, and the functionality of CONC services. Develop mechanism for use of self-assessment and standardized checklist as a quality improvement tool, and build the capacity of district level quality assurance working group to monitor quality of care at the point of delivery. Improve infection prevention and healthcare waste management practice. Conduct site infection prevention training, including proper waste management and placenta pit. Ensure availability of functional toilet and running water facility in the health facility. And revise on-site coaching to ensure the continuity of proper infection prevention practices in facility, including focus on hand hygiene. Strengthen quality assurance system. Develop a system to monitor the strategic objective 3. To monitor, strengthen quality assurance system. Develop a system to monitor the quality of care at the point of service delivery from pregnancy though to the newborn period that include monitoring of preterm prevention in ANC, use of corticosteroid for management of preterm deliveries, infection prevention in maternal and newborn healthcare, stillbirth attendant delivery, and the functionality of the CUNC services. Develop mechanism for use of self-assessment and standardized checklist is a quality improvement tool, and build the capacity of district level quality assurance working group to monitor quality of care at the point of delivery. Improve infection prevention and healthcare waste management practice. Conduct site infection prevention training, including proper waste management and placenta tips, PIRS. Ensure availability of functional toilet and running water facility in health facilities, and revise on-site coaching to ensure the continuity of proper infection prevention practices in facility, including focus on hand hygiene. Objective 3. Strategic Objective 3. Equitable utilization of healthcare services. The current form of the free healthcare policy provides free essential healthcare services, including maternity and child health services, but it is yet to encompass this newborn services into basic package. At present, payment is required for all newborn related services, from the administration of antenatal corticosteroid for preterm deliveries, though or more demanding highly specialized inpatient care in NICU. Bringing newborn care under the umbrella of the free healthcare will alleviate financial barriers that discourage users from seeking care for sick and small newborn. This action plan addresses the significant equity gap dividing the health of the newborn of underserved population. The range of service provided will also be expanded to include more evidence-based intervention. Each health facility will have a space and resource for the health worker to provide basic or specialized newborn care services. Supporting the service expansion will require improvement in infrastructure, national guideline, protocol and training, and adequate resource allocation. In addition, delivery and emergency service will be strengthened to promote healthy birth of newborn, including improving blood transfusion services and evaluating location of birthing center, BUNC and CUNC facilities. Key output and action: improve access to health service, especially for unreached population. Update free health policy to include evidence-based critical newborn healthcare intervention at all levels. Introduce new cost-effective evidence-based intervention to identify preterm and low birth weight babies for timely referral to higher health facilities. Include tocolytics in the essential drug list. Revise the community-based birth preparedness package to include information about the referral system and a new network of available health facility and services. Scale of CBIMNCI nationwide. Ensure the provision of newborn services in all existing birthing centers. Establish birthing and newborn care center with the newborn and KMC corner in strategic and need-based location, considering the underserved community. Expand laboratory service in all health facility in a phased manner in line with the Nepal Health Sector Strategy 15 to 20, and provide free transportation for complicated delivery and newborn to both to and from the health facility. Functionalize health service network, including referral system. Implement national referral guideline for safe motherhood and newborn through the country. Establish transit or stay home at strategic and need-based care center of excellence, birthing and newborn care center and hospital vicinity. Develop a locum system for health worker from regional facility to service district CUNC to conduct a cesarean surgery, and implement a telemedicine or mobile health system to provide support to service provider and increase communication network between the service provider. Strategic Objective 4. Strengthen decentralized planning and budgeting. As the Nepal Health Sector Strategy refocuses its effort on decentralized approach to health sector planning and budgeting, we must ensure that critical services for newborn are adequately planned, budgeted, and implemented. This action plan envisions working with the local bodies and other subordinates authority for participatory planning, budgeting, and achieving their respective target for maternal and newborn health. It proposes to develop authority to local bodies in management of human resources and block grant to facilitate implementation of plan activity at the local level. Strengthening decentralized planning and budgeting also requires central level authority to revise the existing annual planning and budgeting process. It must be informed by the health outcome at the decentralized level by the capacity of local body to deliver the expanded maternal and newborn health services proposed by this action plan. Key output and action: build institutional capacity for strategic planning, evaluate NENAP performance against NENAP indicator in annual district, regional and national review workshop, accelerate the progress of authority transfer and facilitate fund management for human resources to local government, including authorizing the use of block funding and resolving funding gap between fiscal year, build capacity of health facility operation and management committee and increase the involvement of local bodies, BDC, DDC for planning and management of health facility, ensure that maternal and newborn issues are addressed in local health governance planning process, including targeted program for underserved population, provide equal opportunity for capacity development to locally hired health worker to ensure high competency and skill amongst all government and non-governmental health worker, revise national planning process that consider performance of health outcome and delivery of health service at a local level, and strengthen the service of birth certificate provided by health facility to newborn at facility to facilitate birth registration at BDCs. Strategic objective 5: improve sector management and governance. In the next 5 years, the MSP will recognize itself as a for the border state restructuring and the emerging health need. Nepal Every Newborn Action Plan proposes function and responsibility of ministry from community to central level to be revised, including allocation of sanction posts at all tiers of care. The reorganization must be designed to deliver quality maternal and newborn care and meet the ambitious target, a reduction in the neonatal mortality and stillbirth rate. Achieving this target will require the concern and coordinated effort of all stakeholders and effective utilization of available technical and financial resources. The action plan explores new opportunity for public-private partnership with academic institutions and private sector to increase the access, quality and equity of health services. The technical assistance received by the ministry will also be reviewed and better aligned to the priorities to this action plan. Key output and action: improve governance and accountability, develop and implement public-private partnership with medical school and private hospital for human resource to ensure uninterrupted CUNC services, expand use of social audit to improve utilization and quality of maternal and newborn services at the local level, and build a relationship between service provider and communities, and strengthen monitoring and supervision of maternal and newborn program. Improve public financial management, ensure funds for maternal and newborn program are properly utilized through the use of tabacus. Strategic objective 6: improve sustainability of the health sector financing. Sustainable financing is crucial to ensure universal access to critical maternal and newborn intervention. The NENAP call for increasing financial resources such that adequate funds are available to deliver critical newborn services free of charge or with minimal financial burden to client. The action plan also set in place process to improve existing social protection mechanism. The AMA program will be revised based on the implementation lesson of recent year, and as the country move toward scaling up social health insurance and informed benefit package of maternal and newborn health services, including referral benefit, will be provided to the people. Key output and action: strengthening health financing system, develop the costing of newborn intervention to support planning and budgeting, develop free newborn care package, expand budget allocation for maternal and newborn health services at central and local level, improve the efficiency of CUNC funding, including mechanism to encourage gap in funding due to budget release delays, review and inform the budget benefit package for mother and newborn in the social health insurance benefit package. Objective 7: improve healthy lifestyle and environment. Improving service for newborn health will have limited impact if they cannot incite service utilization and orient social behavior toward healthy practices. Building community ownership of local services by enhancing community participation in planning, implementation, and monitoring of newborn care program will increase the awareness of newborn and health and availability of services, and will help maintain quality in service delivery. Inclusion of all representative all community will be critical, including male and female gender and those from all disadvantaged group, to ensure that services are client oriented and equitable across the entire community. Key output and action: promote health practices, lifestyle support and promote breastfeeding through the revitalization of the baby friendly hospital initiative, endorse policy to protect breastfeeding and develop a code of marketing for breast milk substitute, implementation of adolescence and maternal nutrition strategy to improve the nutritional status of expected mothers. developed social behaviors in communication and local languages regarding the importance of preventing preterm labor, birth preparedness, ANC, PNC, newborn care, postpartum family planning, institutional delivery by SPA, timely referral to complicated cases, both maternal and newborn. Increase the awareness of available services at all level amongst female community health volunteer, health worker, traditional leader and communities using the mass media and community mobilization. Implement a telemedicine or mobile health system to raise community awareness about newborn health and service availability, and develop a process to raise awareness of child marriages and delaying of pregnancy amongst adolescents and families using a multi-sectoral approach. Strategic objective 4. Strategic objective 8, strengthen management of public health emergencies. Lesson learned from past experience in disaster, and particularly the recent April 2015 earthquake, shows that our readiness in face of this disaster need to be improved and our responses better coordinated. This action plan will concentrate on revising and implementing protocol and guidelines that will ensure continuity and restoration of critical maternal and newborn services in disaster affected areas, particularly for displaced or vulnerable population. This will include ensuring that post-disaster human resource mobilization plan adequately address the health need of mother and newborn. The adequate buffer stock of medicine and supplies are available at a strategic location, and the rapid response team are financially and technically equipped to respond to disaster outbreak. Key output and action: improve public health emergency and disaster preparedness for newborn care, integrate maternal, newborn and child health into the national health emergency preparedness plan that will ensure continuity of service provision, develop sub-national level protocol and operational guideline for maternal and newborn care during the emergency situation. And even disaster risk reduction component are included for major maternal and newborn program. Proposition buffer stock of supplies and medicine, including rapid response kit required for maternal and newborn care at strategic location at national and sub-national level during disaster, and review human resource mobilization plan for emergency to include newborn specialties. Strategic objective 9, improve availability and use of evidence in decision making process at all levels. Structural and policy reform to drive improvement in service delivery and health workforce require policy and planning that are evidence-based and informed of implementation challenges and success. Nepal's achievement of significant reduction of child mortality can be traced to the use of scientific evidence in public health intervention. The CBI-MNCI newborn care package initiative that link community-based care to health facility and has saved countless children will continue to save life as it evolves into the joint intervention, namely CBI-MNCI. These and other intervention to improve survivability of newborn and stillbirth could still be further improved with relevant data on causes of newborn and stillbirth death in Nepal. Thus, in the next 5 years, the action plan focuses on new research and better inform the sector on these causes, while also focusing our effort at scaling of evidence-based intervention highlighted by the lesson newborn series. Adopting and implementing these intervention at the community and facility level will require routing information system and national-wide survey to measure, report and analyze maternal and newborn related indicators. Nepal newborn action plan will ensure the routing information system will collect and analyze data in disaggregated form to monitor issue of inequalities of access and health outcome at district, regional and national review. The implication will be discussed for their implication in annual planning and budgeting cycle. Key output and action: promote integrated information management approach, advocate for effective implementation and expand the use of civil registration and vital statistics, initiate e-health to monitor the program and for timely feedback and utilization of all level, particularly point of care, ensure global quality NENAP indicator to monitor newborn care are incorporated into the health management information system. Introduce regular monitoring system at all facilities, such as introducing checklists to facility recording information of sick and low birth weight newborn. Implement the maternal and perinatal surveillance and response system from the community to all health facility level, including private institution to support the understanding of case fatalities, and expand the national network for newborn and perinatal database to collect information on newborn morbidity and birth defect and link to HMIS. Conduct survey and research in priority area. perform regular monitoring, assessment, and periodic survey to capture quality of care, conduct research to better understand causes of newborn and mortalities and stillbirth, include newborn indicator and verbal autopsies in national survey, including NDHS and mix that are conducted every 5 years, and in routine health facility survey, and conduct research to assess the effectiveness of new and low-cost newborn care intervention on reducing stillbirth and newborn morbidity and mortality in Nepal. Improve health sector reviews with functional linkage to planning process. Prepare technical brief on strategic issue for maternal and newborn health for national review meeting. Ensure review of maternal and newborn achievement, bottlenecks, and plan for way forward during the annual district and regional and national review, and develop quarterly and yearly plan with benchmark and target for district, regional, and national plan. This will allow consistent monitoring and timely action. Target for success. Indicator to track NENAP. The NENAP presents a significant goal to end all preventable newborn death in Nepal by exploring coverage of quality service and increase access for all population. Regular and sustained progress guided by target indicator will keep the NENAP on track toward this goal. The NENAP monitoring and evaluation framework will be integrated into Government of Nepal existing health management information system. To this effect, some new indicator will be added into the system. The NENAP indicators are aligned to the global NENAP indicator to facilitate comparison to other NENAP countries, in particular our regional neighborhood. Table 3.1. The impact of NENAP intervention will be indicated by changes in mortality rate and birth rate for small and early babies. Notably, the strength of monitoring progress will be depend on the reliable collection and analysis of quality data derived from equipped health facility with trained health worker. The LifeSafe tools software was used to determine the 2035 target for the neonatal mortality rate and stillbirth rate based on the scale up of evidence-based intervention. The outcome indicator selected for monitoring presented in table 3.1 will closely monitor key intervention to reduce mortality from the main non-causes of newborn death in Nepal: asphyxia, infection, and preterm delivery, as well as intervention to improve the management of complication during pregnancy to reduce the incidence of stillbirth. A detailed description of the target setting exercise conducted in list and indicator definition are presented in Annex 4. Maternal mortality ratio in 2035 मा चाहिँ 98 मा पुर्याउने लक्ष्य छ। त्यसै गरी न्यूनेटल मोर्टालिटी रेट 11, स्टिल बर्थ रेट 13, अंडर 5 मोर्टालिटी रेट 21, प्रीटर्म बर्थ रेट 14, स्मॉल फॉर जेस्टेशनल एज 38, प्रेगनेंसी ANC केयर 95, आयरन फोलेट सप्लीमेंटेशन 95, syphilis detection treatment 95, calcium supplementation 80, balance energy supplementation 70, hypertensive disease management 80, diabetes case management 80, MGSFO management of 80, fetal growth restriction detection and management 80. Stillbirth attendant skill birth attendance 95, institutional delivery 95, essential delivery care 10, BONC 30, CUNC 55, clean birth practice 95, immediate assessment and stimulation 95, labor and delivery management 95, antenatal corticosteroid for preterm delivery 95, MGSFO management of eclampsia 95, postnatal care clean postnatal practices 95, fluoxetine cord cleansing 95, exclusive breastfeeding 90, case management of asphyxiated newborn resuscitation 85, case management of preterm newborn 100, thermal care 10, kangaroo mother care 35, full support care for prematurity 55, case management of newborn infection 100, oral antibiotic 10, injectable antibiotic 35, full supportive care for sepsis 55. References: Annex. Demographics of service utilization and mortality. Newborn mortality and perinatal mortality among birth in the 10 years preceding the mixed 2014 by mother's background characteristic. You can see it here. I have skipped this. Bottleneck analysis of newborn care in Nepal. To facilitate the deployment of a strategy for NENAP existing challenge and issue currently inhabiting effective service delivery of newborn services or assess using the global every newborn steering group bottleneck analysis tool. The process uses a two-part analytical approach to identify the bottleneck and solution. An analysis of bottleneck within individual health system block related to all newborn services was first conducted. The identified bottleneck were then prioritized is either good, need some improvement, need major improvement, or inadequate. Then for each high priority bottleneck strategy or solution will recommended. A second analysis was then conducted concerning bottleneck specific to service delivery of 9 critical newborn interventions that are evidence based, known to be high impact in reducing newborn mortality around the critical day of birth from the time of labor to the immediate postnatal care period. For each intervention, a proxy procedure or set of procedure essential to the critical intervention was analyzed for bottleneck in terms of health system block. For example, as a core component of skill care at birth, the use of partograph was discussed in analysis similar to the first analysis, but the bottleneck were prioritized and solution were then determined. The 9 critical intervention and proxy procedure: prevention and management of preterm birth, detection of women at risk or in preterm labor, use of tocolytics to delay labor or different route of delivery, proxy use of antenatal corticosteroid to promote long maturity before preterm delivery, skill care at birth, delivery by skill birth attendant trained to manage normal uncomplicated delivery, immediate newborn care, and the identification and management of complication, proxy use of partograph to facilitate regular monitoring of mother and focus during labor for the early detection of complication, basic emergency obstructive and newborn care, the performance of 7 signal function to manage complicated delivery without the need of an operating theatre, proxy assisted vaginal delivery that include the use of vacuum device or forceps to facilitate vaginal delivery of a baby, comprehensive emergency obstructive and newborn care, the performance of 9 signal function including cesarean section and safe blood transfusion, proxy cesarean section and abdominal surgical procedure for the delivery of baby, basic newborn care for all, newborn prevention procedure to promote the survival of all newborn, proxy cleanliness, warmth and breastfeeding that include the hygienic practice, thermal control, drying, warp, delayed bathing and breastfeeding support, newborn resuscitation procedure at a time of birth to establish breathing and circulation, proxy use of bag and mask to facilitate breathing, kangaroo mother care procedure to support premature and small newborn weighing less than 2 kg, proxy skin to skin breastfeeding and feeding support to help regulate newborn and temperature and foster good feeding practices, management of severe newborn infection, require proper assessment capacity to deliver injectable antibiotic and full supportive care, proxy use of injectable antibiotic to treat infection, inpatient supportive care for sick and small newborn, provision of regular monitoring and assessment of newborn who are unable to maintain body temperature, breathe or feed through inpatient care, proxy intravenous fluid feeding support and safe oxygen that include the provision of intravenous fluid, application of an intragastric tube feeding and safe oxygen administration. Involved in the process was a wide range of stakeholders with intimate knowledge and close experience of the issue at hand. They included health worker and health manager at the first line delivering health care, policy maker, district and central level representative from various MSP division and expert in newborn care from various international government and non-government deployment agencies. Summary of benefited bottleneck. The bottleneck analysis elucidated the extent of the tasks at hand and highlighted which intervention and health system block present the largest challenge requiring significant attention in the NENAP. In terms of health system, major gap were deemed to be in health financing, workbooks, essential medical product and technologies and governance. The analysis by critical intervention highlighted that management of preterm newborn, management of sick and small newborn, kangaroo mother care and newborn resuscitation require better implementation. Out-of-pocket expenses are a barrier that deter users from seeking health care for their care sick and small newborn, which can lead to the mortality. Although immediate postnatal care for healthy newborn is free as part of delivery services covered by basic health care package, payment is required for treatment of sick and small newborn, for example antibiotics or service in newborn intensive care unit. The health workforce for newborn care was considered to have deficiency in several areas. There is low competency amongst the health worker, which is acute in management of preterm newborn and newborn resuscitation and inpatient care for sick and small newborn, primarily due to insufficient training, lack of supporting national guideline and poor supportive supervision. The availability of health worker is also low due to on-field sanction position and high absenteeism in rural health facility, compounded by central level restriction on local hiring, centralized planning and delayed budgeting. The practice of the critical newborn intervention is not well institutionalized within the service provided for newborn. Multiple factors including incomplete guideline and standard, lack of training and poor supporting infrastructure and equipment has prevented health worker from effectively implementing the life-saving intervention. Kangaroo mother care is the last well practice into no guideline training or private space within health facility for mother to provide life-saving skin to their newborn. Other interventions such as management of preterm newborn is compromised by the underutilization of antenatal corticosteroid and tocolides, the latter of which is not listed on essential drug list. Many health facilities also lack essential equipment such as bag and mask ventilation to perform newborn resuscitation. Summary: priority making bottleneck by health system blocks and intervention. Health system intervention: leadership, government, self financing, health workforce, essential medicine product and technology, health service delivery, health information system. Community participation and ownership, management of preterm birth, skill care at birth. You can see red, green and yellow highlighted. BUNC, CUNC, basic newborn care for all newborn, newborn resuscitation, kangaroo mother care, is one different color. Management of service, severe newborn infection, inpatient supportive care for sick and small, good, green. Need some improvement, need major improvement, inadequate. Proposed CBIMNCI newborn services from the community up to ward level, PHURC, community health unit, urban health clinic, health post without birthing center, with birthing center, primary health care less than 5 bedded. Okay, we are going to read it. Level: community up to ward level community, counsel the mother and caregiver on essential care for newborn, danger sign for newborn, postpartum women and place for the management of sick newborn and women, provide chlorhexidine gel for pregnant women and counsel about its use, counsel about the importance of exclusive breastfeeding, supplementary food and growth monitoring. Program CBIMSA, Cardi female community health volunteer would be supported by local volunteers, social worker and child friend. Assess the baby with danger sign, provide zinc and ORS if the baby has diarrhea, refer the baby to health facility for further management. If the baby has dehydration and dysentery, refer the baby to the health facility for treatment. If the baby has pneumonia, air infection, fever or any danger sign, counsel the mother and caregiver on essential care for newborn, danger sign for newborn, postpartum place, provide chlorhexidine gel for application to baby's umbilical stump and counsel about its use, counsel about the importance of exclusive breastfeeding, supplementary food and growth monitoring. Here we can see a various activity which can be done or which are doing by PHCORCs, community health unit. We can see some PHCORC with the additional facility of management of severe dehydration with IV fluid and severe diarrhea, CBIMNCI program, Guardia health worker, urban health clinics, same service provided by the community health unit, health post without birthing center, same service provided by the community health unit, with birthing center, immediate newborn care, resuscitation for non-breathing babies, early incision of breastfeeding, waiting the newborn, treat and manage newborn infection and refer to as per need, KNC counseling, skin to skin, feeding support, birthing center, same service provided by community health unit on operation day of newborn care, primary health care center, immediate newborn care, in operation theatre and labor room, immediate newborn care, resuscitation for non-breathing babies, early initiation of breastfeeding, waiting the newborn, referral if the baby is sick, KNC unit KMC skin to skin contact on demand breastfeeding early discharge for baby weighing 100 to 1800 gram who are stable, referral if the baby is unstable. SPA program is SPA. Laboratory service, the total serum bilirubin, HbSAg, HIV test, blood grouping, total blood count, blood glucose and urine albumin for pregnant women. Pre-treatment for sick newborn care corner in operating theatre and labor room, immediate newborn care, resuscitation for non-breathing baby, early incision of breastfeeding, waiting the newborn, referral if the baby is sick. Under 15 hospital, bedded hospital, KMC unit, especially for baby weighing 1800 gram who are stable, referral if the baby is unstable. Special newborn care unit, feeding support, warmth, IV fluid, infection management, safe oxygen, phototherapy, refer babies of birth weight more than 1.5 kg, follow up and manage sick newborn, and refer babies less than 1.5 kg and who require CPAP and ventilation services. Special newborn care unit, laboratory service plus blood culture, renal function test and urine culture. Special newborn care unit package. Okay, you can see here are different type of services provided by different health facilities. An expo target setting of mortality and indicator using list computer modeling. The 2035 NENAP target for the neonatal mortality rate and stillbirth rate was determined using the computer-based model list, which estimate the impact of increasing coverage of evidence-based intervention on maternal, newborn and child mortality. The intervention selected into the list model included severe cerebral key intervention to improve the care during pregnancy, childbirth, management of sick or premature newborn and essential postnatal care. In addition, is part of continuum of care, pre-pregnancy family planning and safe person service to improve maternal health and pregnancy planning, infant nutritional supplementation and improve water and hygiene intervention to reduce the incidence of waterborne diseases, and infant diarrhea were included in the expanded list analysis. The coverage of intervention in 2015 was set by the as the base year, which was derived from the various data sources. For example, NDHS mix coverage target for 2035 were then set for each intervention from baseline to target coverage. The figure were interpolated based on the single year intervals based on the previous 5-year annual rate change. Using the resulting scale of coverage of the included intervention, list modeled projection estimate for NMR, SPR, maternal mortality ratio, proportion of neonate born preterm and proportion of neonate born small for gestational age, SCA between 2015 to 35. The interpolated calculated coverage for the various intervention between 2015 and 2035, and the projected mortality SCA and preterm incidence is presented below with the definition of the indicator. You can see here various type of indicator. Definition indicator: maternal mortality rate, maternal death per lakh live birth, neonatal mortality rate, newborn death per 1000 live birth, stillbirth rate, stillbirth per 1000 total birth, under 5 mortality rate, under 5 death per 1000 live birth, preterm birth rate, proportion of newborn born preterm, small for gestational age rate, proportion of newborn born small for gestational age. Outcome peri-conceptual. Here are folic acid supplementation fortification, percentage of married women receiving folic acid supplementation for fortification at conception, safe abortion service, percentage of termination that are performed safely, post abortion case management, percentage of women treated for abortion who receive post abortion care, pregnancy antenatal care 4 visit, percentage of pregnant women with at least 4 antenatal care visit, tetanus toxoid vaccination, percentage of children protected at birth from tetanus, syphilis detection and treatment, percentage of pregnant women screened for syphilis with the rapid plasma reagent test and treated if needed, calcium supplementation, percentage of pregnant women taking 1 gram of calcium per day, iron folate supplementation, percentage of women receiving 90 plus days of iron folate supplementation, balanced energy supplementation, percentage of undernourished pregnant women receiving high protein and calorie dietary supplementation, hypertensive disease case management, percentage of pregnant women with the hypertensive disease that are managed appropriately, diabetes case management, percentage of women with the diabetes that are managed appropriately, NGSFO management of preeclampsia, percentage of pregnant women with the sign of preeclampsia that are treated with NGSFO, fetal growth resuccination detection and treatment, percentage of pregnant women who are detected with the fetal growth resuccination using appropriate equipment and who are treated if needed. Childbirth attendant, stillbirth attendant, percent of delivery by the stillbirth attendant, institutional delivery, and percent of infant delivered in a facility, essential care, percent of delivered in essential birthing care facility, BUNC, percent of infant delivered in BUNC health facility, CUNC, percentage of infant delivered in CUNC level facility, clean birth practices, percent of neonate delivered with appropriate clean birth practices and washing, cleaning the pericum, calcon birth service, clean cord cutting and clean cord trying at home or in a facility, immediate assessment and stimulation, percentage of neonate with appropriate drying and stimulation immediately after birth under the care of skilled birth attendants at home or in facility, labor and delivery management, percentage of neonate delivered under the appropriate standard for each given place of delivery, including SPA in home and SPA essential care facility with appropriate equipment and infection control, health worker, BNCL facility are functional, in 7 signal functional and health worker of CUNC facility that are functional in 9 signal function. Here are different indicators. I am going to skip this because it took me too much time. You can see here I just skipped slowly. Nepal Every Newborn Action Plan Implementation Plan 2016 to 21. NENAP IP has been developed based on the guiding framework of Nepal Health Sector Strategy 15 to 20. The NENAP implementation has been developed for the period of 5 years, 16 to 21. The NENAP implementation plan will be used as a basis to translate the plan in the annual work plan and budget for responsible division in Department of Health Service. The NENAP IP Nepal Every Newborn Action Plan implementation plan document will be reviewed on the annual basis to track the progress made in the implementation of implementation plan, key output and intervention. NENAP IP development team, supporting agencies. Thank you so much for your patience, and if anything you want to say me, please comment on the comment section. Thank you so much everyone.